Well, friends, very good evening and welcome to 19th Uveitis webinar on a very important topic of immunosuppression. Well, we all have been together for the last 19 months, every first Saturday of the month, and you guys are all like a family. And I'm very sorry to share with you the news of passing away of the person who started these webinar series, and that's Manfred. Manfred did a lot for all of us in the field of education, starting the Venice course, which many of you would have been a part of. Not only the Venice, Addis Ababa, starting so many educational activities and courses in the countries where the knowledge about ocular inflammation was essential. And nobody ever thought of it before him. He was the person who started, whose idea it was to start the uveitis webinars, starting with January 13, 2021 was the first time when we all met. He already has planned up to 36 webinars, and believe me, everything is in place. So he wanted it to be available to all the persons who are interested in uveitis, and it should be accessible at any time free of charge. So these are available on our IUSG website to everybody. And it's not only for the members, but anybody who wishes to know about uveitis and even look at these courses backwards. He has also started IUSG Ambassador Program, and I'm very happy that it is expanding. And now John Campen and many others of you are taking the lead. Rola is here for Middle East. So we are going to try to reach out to as many people, because it was Manfred's dream to have the uveitis education reaching to those parts of the world which are not very easily accessible. We also have the patient support system on our IUSG website, where all of you with any kind of challenging cases could reach out to the moderator, and all our members from IUSG who are, the world-class people in uveitis would be very happy to hold your hand and help you in the case management. For those of you who do not know, Manfred last year was diagnosed with a malignancy, and even while he was receiving his chemotherapy, he continued his education, he continued his Zoom meetings, and many of you may have noticed or not noticed, but he was working till the last day of his life. And the fighter that he was, he truly fought very hard, but somehow maybe God wanted him with him. So on August 22, he said goodbye to us. Well, Manfred in physical form is not with us, but his legacy will always continue. And we will try to continue whatever he dreamed of. And we do hope that with all the friends and all the experts, we would try to follow the path that Manfred wanted us to follow. Thank you very much, everyone, for being here. And thank you, speakers, for being here despite your busy schedules, because a lot of us are traveling now and the things are, not so easy. So with this, I would like to invite our very first speaker, that is John Campen. And we cannot have a person better than John talking about immunosuppression. And John is going to talk about indication and management of immunosuppressive drugs. And all of you, as usual, please write your questions, type them in Q&A, and our speakers would be very happy answering them for you in between the talk. Over to you, John.
Good. Well, good morning or good afternoon to everyone. And I'm pleased to talk about this issue of immunosuppressive therapy that I've spent much of my research life working on, and which I regard as sort of a distinctive of the uveitis specialist to be able to apply this kind of treatment to relieve ocular inflammation. So I'm going to discuss the rationale for using such therapy, and then to review sort of the principles of management. And some of our talks may overlap a little bit as we address this issue. So apologies if I sort of take any material from the subsequent lectures, but I'm trying to focus on these two issues. So why would we use such therapies? So Stephen Foster, a famous pioneer of this kind of treatment, told me that when he began doing this kind of treatment, that other famous ophthalmologists were scandalized that he would use such dangerous treatment. But it's proven over the time that it isn't really so dangerous and it's really useful. But if we think about this, when we're managing a patient with ocular inflammation, that's the patient's fundamental problem. And it leads to various complications that we need to address, but we have to address the fundamental problem sort of as the priority, and then deal with the complications by taking steps to minimize them or alleviating them in some way. So we need to do what's necessary to control inflammation, and then choose approaches that minimize side effects. And people often talk about a stepladder of managing these conditions, and that sort of implies that each treatment is sort of more sort of aggressive. But actually the immunosuppression proves to be less aggressive than chronic high-dose oral steroids. And so the management is really related to minimizing side effects while still controlling inflammation. So in general, when we're managing uveitis, I like to think of sort of two phases of treatment. Induction, which is sort of suppressing the active inflammation, and then suppression, which only applies to the chronic cases, which are the ones that are going to tend to do badly. And so immunosuppression really mostly fits into the suppression category. There might be some sort of exception where it's used to address active inflammation as a primary treatment, but usually it would be sort of steroids, supplemented by immunosuppression to induce control of the inflammation, and then immunosuppression with progressively less steroids to maintain control of the inflammation. So the rationale for using this kind of therapy is sort of learned from rheumatology. So immune modifying therapy is obviously useful for immunological disorders, of which the majority of uveitis and ocular inflammation cases are. And so while we have various approaches to treating ophthalmic disease, since the eye is exposed and we can get at it with eye drops and injections and so on, the systemic therapy has been the workhorse for managing the chronic severe cases that are most likely to cause vision loss. And we've shown, I'm not going to show the data, but that the patients can do well and be stable or improved over long periods of time. And in terms of using potentially toxic therapy, and we're going to argue that it really isn't that toxic, but even if it was, sort of disability adjusted life year type studies have shown that people view blindness very adversely. And so therefore it's worth doing some things that might cause some side effects in order to maintain vision. But we'll see that we mostly can avoid side effects by applying sort of rheumatological principles in the eye clinic. So talking about immunosuppressive therapy, at least for my talk, would be using immunosuppressive agents that don't include corticosteroids and nonsteroidal anti-inflammatory drugs. And we're going to subsequently have a detailed enumeration of all these drugs, but they're sort of like drugs borrowed from rheumatology and transplant. When we give systemic therapy for eye disease, it has the advantages that it's sort of easy to administer and to sort of know how much you're giving. And it also tends to avoid local side effects. So people that are strong steroid responders or for whom a cataract would be disastrous, there's less risk of that with systemic therapy, and especially with immunosuppressants and not steroids. The disadvantages are that you could have systemic side effects, especially if you're not managing it well. But these are usually temporary because we can address them by adjusting the regimen. And in some cases, the cost can be high, although in other cases like methotrexate and azathioprine, the cost isn't so high. And another important issue is that the immunosuppressive drugs tend to be slow in onset and they don't always work. So steroids nearly always work and they work very quickly. Immunosuppressive drugs can take many months to work and don't always work. And so it takes time to get the regimen worked out. The biologics, I think, tend to be faster, but in general, nothing is as fast as steroids. So this is sort of the published set of indications for using immunosuppressive drugs from an expert panel report now more than 20 years ago. And so the most common one is the second one, as corticosteroid sparing therapy, that is to maintain control of inflammation while avoiding the greater toxicity of high-dose corticosteroids. And then the others are failure of corticosteroid therapy to control inflammation, and then specific diseases where we sort of anticipate the case is going to fall into one of those categories, which Professor Hammam's talk is addressing that. So in terms of the failure of corticosteroid therapy, this could be practically viewed as when the patient's getting worse instead of better on high-dose oral steroids and topical steroids if applicable, or if you fail to completely control inflammation in a month with high-dose prednisolone, then you're going to be anticipated to cause a lot of side effects from that. And so then you would want to get going with immunosuppressive therapy. Let me just note that if this happens, you want to be very careful to consider whether it might be an infectious case, because usually the corticosteroids will work. And then for the steroid sparing, we might use this at an earlier stage if there's a potential issue with high-dose corticosteroids, like with diabetic patients and so on. We might use early corticosteroid sparing therapy. Sometimes we end up doing this when the patient's sort of very sensitive about weight gain they might have had with high-dose corticosteroids before. And so we kind of just get going with this early to sort of persuade them to do what they need to do to control their eye inflammation. So the available agents will be covered by Professor Chimino, but I'm going to briefly mention them. So getting back to the issue about, that scandalized people at Mass Eye and Ear while Foster was beginning to use this, are they really safe? And so I'm going to go through the considerable data briefly about this to sort of persuade you that they generally are safe. So I have to kind of give the major categories of immunosuppressive drugs to talk about this, but he'll look over or go through that in more detail. So this is a summary that we made for the MUST trial of the site results about the outcomes of some of the most commonly or more commonly used drugs. And I've just highlighted the discontinuation rate for side effects. And so you can see, maybe 1 in 6 or 1 in 7 cases is going to stop for side effects. And but most of them aren't. And then in some cases it doesn't work. And so, maybe 25% of the time they fell into that category. We got a little bit less favorable results for how many accomplished the steroid sparing goal, but this study, which was looking at sort of visits, it tended to capture benefits late, and this might be a little bit underestimated. I think probably 2/3 is often or 60% is often a good expectation for success with the first agent. So you see, you do get side effects, especially with alkylating agents, and you have to monitor for these, but generally they can be reversed by either reducing the dose or changing treatment, or sometimes the patient gets accustomed to it if they're just feeling bad. So what about sort of medium-term adverse outcomes? So in the MUST trial, we compared a purely local treatment with the Retisert implant to systemic therapy, which involved immunosuppressive drugs in about 90% of patients sort of following the principles of steroid sparing or the indications that I mentioned previously. And so when we looked at sort of potential corticosteroid complications, the ones that we're trying to spare by using immunosuppressive drugs, it wasn't statistically significantly different for any of the major categories. It did tend to be slightly higher in the or in the systemic therapy group where corticosteroids were used, oral corticosteroids were used, but all of these were infrequent except for osteopenia, which was equally frequent in both. And this was over, I think, 7 years. So it's there would be some fractures. When we actually looked into other things, this didn't appear to be as different as it looks. But again, this is not statistically significantly different. So we largely avoid these by using immunosuppressive drugs for uveitis. This is, a uveitis trial for intermediate posterior pan uveitis. And then when we look at the things that we monitor to try to, to see if we're causing any side effects, we really saw very little signal. Where in fact, for 3 of the 5, it was actually a little bit more in the implant group, but none of them were significant, and they're all a small percentage. So we're not, seeing that many problems as we manipulate this. And so it's a little bit artificial because basically if we did see a problem between visits, then we would make adjustments to avoid the problem. But then in the long run, that's perfectly good, because that's what you do as your treatment approach. We did see a higher number of patients that required antibiotics for some infection during the 7 years. But I would argue that this may not really be a real difference, because if you go to your primary care doctor and you said, I have a fever and a runny nose, and this is all before COVID, and they'll say, okay, I'm sorry, but it'll get better soon. But if you say the same thing and you say, and I'm taking oral steroids and immunosuppressive drugs, then you're likely to get a prescription. And so I'm not sure if this is really real, but we did see a statistically significantly greater propensity to prescribe for infections. When we looked at hospitalization from infection, it didn't differ. In fact, it was maybe slightly more for the implant. This is for all hospitalizations, but for hospitalizations from infection, it was not different. And then even looking at weight over the time, the 2 groups were really about the same. So you would expect a little bit of weight gain in the induction phase with the high dose oral steroids, but over the 7 years, most of the time you're going to be at a manageable dose of corticosteroids. In the SITE study, we're about to publish sort of a new set of data that have sort of similar favorable results, but these were the results from the one we published. I can't really show the one that we're about to publish since this is going to be posted online. And I don't want to be unable to publish it, but you can see that basically for the commonly used immunosuppressive drugs, there wasn't a higher risk of death or of death from cancer. And, we tended to see a bit of a signal for TNF inhibitors in this first study, but the subsequent study doesn't show that at all. So it was probably just due to some sort of random cases with the etanercept in particular. We're not seeing at all any signal from mortality or cancer mortality in the larger study that sort of has enough information to evaluate that category. So how do we use them? So first of all, it's important to rule out infectious uveitis. Now, we do occasionally use immunosuppressive drugs along with anti-infectious therapy, such as for tuberculous uveitis, because we often give some sort of systemic anti-inflammatory therapy to minimize the collateral damage, but it's always secondary to the anti-infectious treatment. So the paradigm is going to be totally different if it's infectious. So we have to be careful to rule that out and sort of keep this possibility in mind if the treatment's not going as expected. It requires lab monitoring for virtually all of these drugs, and this, I think, tends to intimidate some ophthalmologists, but it's really not that difficult once you think about it. And there are a minority of patients who have trouble tolerating specific immunosuppressants. Like sometimes people taking methotrexate will feel sick for about 24 hours after they take it once a week. And so we just tweak it in order to overcome these problems. But generally one can lower the dose or switch between drugs and then succeed with an alternative regimen. So what are the issues that we have to consider. So some patients refuse. This was one of the main reasons for doing the site study, was to try to sort of address that kind of issue that patients had. And some, like there's an international organization in Switzerland that explicitly says that cyclosporin and azathioprine are carcinogenic, and so we can see that on average, we're not seeing an increased incidence of overall death or cancer. The forthcoming data will show that for cancer as well. We need to basically avoid immunosuppressive therapy in pregnancy and rely more on steroids temporarily, and especially with methotrexate and alkylators, which cause abortion and are teratogenic for any babies that survive, and mycophenolate, which is also sometimes teratogenic. So these are strongly contraindicated in pregnancy. Azathioprine and cyclosporin have tended to have a relatively good profile. And so like transplant registries of teratogenicity have not shown any differences between transplant patients who continued cyclosporin and those who weren't on it. And so, these may be safe, but we still don't really recommend using immunosuppressive therapy during pregnancy unless it's critically important. So you would want to use, one of these drugs probably if you were going to do it during pregnancy. And then another issue on the other side is that some people have associated systemic disease and need to take immunosuppression for that. And so then we're going to, do what the rheumatologist says, or if it's a transplant patient, what they need for their transplant. And that will usually help us make our treatment easier. Sometimes we might need to kind of discuss with them if we could use a certain drug, like if they had multiple sclerosis, mycophenolate is supposed to be effective for both uveitis and multiple sclerosis. So a lot of ophthalmologists who are surgeons, don't really feel comfortable managing immunosuppressants, which is sort of the essence of a physician's kind of work, or rheumatologist. And so there's 3 approaches to that. One of them is to just become comfortable, to learn to manage the immunosuppressants yourself. One is to partner with someone who manages the immunosuppression, sort of following your guidance as the ophthalmologist managing the disease, or you can refer to a program, if available, with one of the sort of recognized specialists in the area that could take care of this. Now, if you're doing this approach where you're partnering with someone, it's ideal if you can see the patient together, because the ophthalmologist is going to typically want to increase the treatment if there's any suggestion of activity, and the rheumatologist is going to typically prefer to decrease the treatment. And so it's sort of, if they're going to one doctor and then to the other, the treatment might be going back and forth, higher dose, lower dose, higher dose, lower dose. So you have to have good communication if you're not going to do it all yourself. I like doing it myself because, then I don't have that kind of issue. That's what I mean by the ping pong back and forth and back and forth. So in terms of laboratory testing with managing this, we want to do certain testing before we treat. So again, we want to rule out infectious diseases first. And probably the most useful thing for that is to learn to recognize infectious uveitis patterns. But we want to address certain things, like most people would test for syphilis and tuberculosis potentially in an endemic area, and maybe Lyme disease in an endemic area. And sort of depending on your area, there might be certain things that you routinely test for. If you're going to treat with TNF inhibitors, you specifically need to test for systemic TB, even if there wasn't ocular involvement, because it could activate that. And we need to assess for pregnancy if the patient's a fertile female. Many people will just do a lab test for that, but you can sort of use your judgment about that. And then we want to do some hepatic, renal, and blood pressure kind of workup, as well as I like to check for chronic infectious hepatitis in my patients if I'm thinking of putting them on methotrexate or azathioprine, because liver issues will tend to relatively contraindicate antimetabolites and possibly immunosuppression in general if they have chronic hepatitis, although sometimes that's used actually as part of the treatment, but it needs to be approached differently if they have that. And then if they have renal disease or hypertension, sort of the calcineurin inhibitors tend to be relatively contraindicated. And also if they're older, like we found in the site study that 55 and up had a much higher chance of discontinuing therapy probably related to hypertension. And then if they have congestive heart failure or something, you need to keep that in mind if you're going to be treating with infusions of biologics. So in general, I like to start with a lower dose and gradually scale up. This kind of gives the patient time to get accustomed to the drug and not just kind of instantly reject it, especially if they're very anxious about taking the treatment. And so the conventional immunosuppressants are in that category. The biologics probably don't require this as much, although there's some strategies that sort of do start at a lower dose. Some of them actually start at a higher dose first, sort of as a induction kind of concept. And if you're starting with a lower dose and scaling up, which especially would be with methotrexate that has infrequent dosing just once a week, it's going to take longer to reach the therapeutic dose. So that might be why in our study comparing methotrexate to mycophenolate, simulating a trial, that it took longer to succeed with methotrexate, whereas in the FAST trial, they were about the same or even maybe a little better for methotrexate. Since it can take a very long time to succeed with immunosuppressive therapy, I prefer to push, however, to a sort of higher end of the dosing range at the beginning, because I want to know as soon as possible if the drug's going to work. And then sometimes I have to cut it back if the patient's feeling sick or if there's a so-called transaminitis or something like that, liver enzymes elevated. Our goals in the treatment are to have quiet disease on oral steroids of 7.5 milligrams per day or less. Some people would say 5 or less, and 1 drop of prednisolone acetate, 1% or less. And some people would say more than that, but again, some forthcoming evidence suggests that the risk of cataract is substantially higher at 2 drops a day or more. We want to have no important side effects. And if we're treating with alkylating agents, which isn't done too frequently these days, we want remission, not just suppression, because we don't want to treat with those forever. So there was a complicated monitoring approach that I think was sort of adapted largely from rheumatological practices and the consensus paper from 2000, but I think almost everyone finds this too ponderous to do. And so I simplify it by checking the complete blood count and chemistry panel, including liver and renal analytes, monthly, usually just twice. And then if it's stable, I change it to quarterly. Some people might be a little more aggressive than that, but you saw in the MUST results that we really don't see abnormalities that often. And liver enzyme monitoring is going to be required for just about all agents. If you're treating with calcineurin inhibitors, you want to monitor blood pressure, and arguably you might want to do that for steroids too. And so that's important to keep in mind, and especially if the patient's older. And if you're treating with alkylators, the lab monitoring has to be a lot more intensive. You have to look at the complete blood count every week, and actually you're looking to lower the white cell count to a certain level of about 3.5 to implement this to the therapeutic level. But they can be a little unstable, and so you have to keep that in mind. So you also have to sort of assess if the patient's, tolerating it well. And so I think just not feeling good is the biggest constraint on the dose, but we have to be a little careful. Like we don't want to counsel the patients in such a way to lead them to think that we're really anxious about these drugs as opposed to corticosteroids, because really we're less anxious about them. And so we want to kind of find out if they're having an issue without kind of provoking them to do sort of a rumination bias and think of the problems they might be having. And there are some specific side effects to look for with each drug that I think will be covered in the subsequent talks. With alkylators, they frequently cause infertility, like half the time, at least with cyclophosphamide. And so people will consider sperm and egg banking. This, I think most people don't want to get into, and is one of the reasons that we don't use these drugs very often, except if we think the patient will be blind without them, or if they have a systemic disease that they need it to save their life, which is tending to get replaced by rituximab these days. With alkylators, we expect to discontinue steroids rather than having steroid sparing over 12 to 18 months. And we saw at site that it frequently needs to be discontinued for toxicity, and intensive monitoring is required, and so it's harder. But it does induce remission, it seems, in maybe the majority of patients. And so that's sort of a plus. And this sort of short-term chlorambucil approach that people have been mostly afraid to use seems to be looking pretty good in our safety side effects. So, that might be making a comeback in the years to come. We'll see. We can use combinations of immunosuppressants if we're not getting success with the single immunosuppressant. And that probably has more risk of infectious complications, which are otherwise not that common. Maybe herpes zoster ophthalmicus we'll see from time to time, or herpes zoster. But it's probably more if you're using combination immunosuppression. And people have often recommended combining an antimetabolite with the calcineurin inhibitor, since they have sort of a different spectrum of side effects. Although some people will combine methotrexate and mycophenolate, so that's sort of controversial to do that. But combinations have sort of become less common since TNF inhibitors have been available, because usually people just escalate to TNFs. They seem to work very nicely. But people often will use an immunosuppressant, usually methotrexate, in combination with TNF inhibitors, especially if it's not a fully human molecule. You can get an immune response against like the mouse component of, say, infliximab, and then it can neutralize the drug or even cause anaphylaxis. And so people have been adding methotrexate sort of routinely with that one to, it reduces the incidence of anti-drug neutralizing antibodies. And it probably helps it to work better too. So then if we're thinking about how we would manage different categories of patients, if you have an anterior uveitis case, you'll start with topical steroids, usually maybe oral steroids if they have tremendous inflammation. And then if that isn't sufficient, we'll go to oral steroids. Sometimes we'll use depot steroids if we expect it to remit, but depot steroids are a little bit difficult to know when it's going to wear off. So if it's a chronic disease, the oral tends to be my preferred. And then we might go to an antimetabolite. If we have a certain situations like juvenile idiopathic arthritis, we might go to this sort of before this, but this is usually how it's done. And then we might go to a combination or biologics, and not usually alkylators. For intermediate uveitis and for pan uveitis, it would be similar, except that we're going to be starting with oral at the beginning. So what does immunosuppression not accomplish? So it doesn't directly treat macular edema. So that's a leading cause of visual loss, and we want that to get better. It indirectly treats it, because if you can keep inflammation controlled regularly, then you'll tend to have that get better, but not always. And so if it's not getting better when they're quieted, you're going to rely on other treatments like steroid injections to try to clear that. And then there's other things being developed. And some people have argued about interferons seem to work well for that, and new biologics. Also, the immunosuppression usually doesn't succeed and usually isn't used for inducing control of the active inflammation at the beginning without steroids. So we really mostly rely on steroids for that, with probably a few exceptions. So in summary, then, immunosuppressants are a critical weapon to avoid inflammatory blindness. I think before the 70s, when this concept was introduced by Foster and others, we had a lot of problems with steroid side effects or else blindness on alternative ends of the spectrum. And primarily it benefits us by allowing us to control inflammation with less side effects, and also to control associated systemic diseases. We have to manage it thinking like a rheumatologist, and there are some contraindications exist, but it's a generally safe approach to therapy. And a sort of long-term patient relationship is key, and you have to kind of have a way of counseling patients that doesn't lead them to reject the therapy, because basically we have strong evidence now that it's safe, and the problems that we have can be addressed by the management. Thank you very much.
Thank you. Thank you, John, for very clearly elaborating on why should we use immunosuppression. And now we go on to Professor Rola Hammam, who will talk about the uveitis entities which need an early immunosuppression. Over to you, Rola.
Hi, good afternoon or good morning. I'm going to talk about uveitis entities that need early immunosuppression. Just to review the goal of treatment in uveitis, we need to maintain the functional and anatomical integrity of the eye. We need to prevent structural complications that are caused by uveitis, cataract, glaucoma, synechiae. We would like also to preserve or restore vision, but also we want to reduce the symptoms, reduce the local and the systemic inflammation if possible. We want to minimize the treatment side effects and reduce recurrences. So when we treat active uveitis, the goal is to get to quiescence, but also we need to treat quiescent uveitis to prevent recurrences. When do we start early immunosuppression? In a case like this, the young patient with such aggressive inflammation in the back of the eye, this is eminently vision threatening. This is a Behçet patient. We also know that even one recurrence of the disease might be detrimental to the vision of such a patient. In such a case, maybe it's easy to decide that this needs early immunosuppression. What about a case like this? We have posterior uveitis, some macular edema. Do we need to initiate immunosuppression early? Is there a window of opportunity for treatment with immunosuppression, and is treatment time sensitive? We know that with repeated episodes, especially of inflammation and uveitis, we have cumulative damage that is caused. So if we don't treat too early, sometimes we might be too late. And then when we start the treatment, we would have damage and would have lost precious vision. So what are the indications from the Fundamentals of Care for Uveitis initiative? The recommendation to initiate non-corticosteroid systemic therapy with immunosuppression included acute disease that is sight-threatening, chronic persistent inflammation, inflammation with exudative retinal detachment, posterior macular involvement, binocular sight-threatening diseases. But also, if the inflammation is severe with a vision that is worse than 2100, if the vitreous haze is significant, 2+ or more, if there is a relapse of cystoid macular edema, or if the disease impacts the quality of life, these were deemed indications to start immunosuppression. But what about specific entities? These are some of the specific entities where we need to start immunosuppression early: Behçet disease with retinal involvement, sympathetic ophthalmia, vodka and agarada, bird-shot choroidopathy, multifocal choroiditis, panuveitis, serpiginous choroiditis, also juvenile idiopathic arthritis, even if the uvea is not involved, but ocular cicatricial pemphigoid is on the list, and Moran's ulcer. But also there are certain conditions that may affect eye, and they may be, the condition itself may be life-threatening: granulomatosis with polyangiitis, polyarthritis nodosa, relapsing polychondritis with scleritis, and scleritis and peripheral ulcerative keratitis of rheumatoid arthritis. So in these conditions, we need to consider, we need to start immunosuppression early. With Behçet disease, we know that active uveitis in this disease increases the chance of visual impairment by 2.5-folds and blindness by 2.7, around 3 folds. So it is an aggressive blinding disease. Like in this 16-year-old boy, presented the first attack, acute painless loss of vision in the right eye, hand motion vision. History is positive for recurrent ulcerative folliculitis. It's his first presentation, not diagnosed yet. And severely compromised vision and severely compromised structures of the eye, specifically the fovea. And in this patient, the diagnosis of Behçet disease was made with a rheumatologist and started on pulse steroids, something that could give us a very fast response, but then immediately started on oral steroids with adalimumab. So we're not going to wait to start immunosuppression in this patient until we have another attack. And the response is very quick. Within 6 weeks, we have an excellent response of the inflammation, and the fovea looks much better with restoration of a very good vision, got back to 20/20. Another entity would be vodka and agarada. We know from the literature that immunosuppression is helpful in preventing structural complications in this disease, but it also decreases the risk of visual impairment and blindness significantly. So this is one of the conditions where we need to start immunosuppression early. This is a 40-year-old female with acute VKH, a significant compromise in vision. We have the exudative detachment bilaterally in this patient. And this is a case where we're going to start immediately immunosuppression with the steroids, of course. And we started her on mycophenolate mofetil with the steroids that were tapered within 6 months. And she was maintained on mycophenolate mofetil for 2 years after that, without any sunset glow fundus, without any chronic anterior uveitis, recurrence of the inflammation, and she did very well, and we were actually able to stop her immunosuppression after that. Birchout chorionopathy, the main morbidity from this disease is usually macular edema and the retinopathy, the damage to the retina. And we know from the literature that to control the macular edema, we need high doses, risky doses of oral steroids, more than 50 milligrams a day. And also the literature suggests that immunosuppression reduces the risk of macular edema in these patients, but also may reverse the visual field loss that occurs because of the chorioretinopathy. It does not reverse it fully, but it helps with that as well. So it is an indication to start immunosuppression early in this condition. This is a 60-year-old female with Birchout chorionopathy and macular edema. She presented after a long time of the disease start, and started her on steroids in addition to immunosuppression. She did not respond well and had side effects with mycophenolate and cyclosporin. Then we had to switch to adalimumab with methotrexate in addition to 7.5, less than 7.5 milligrams of steroids. And then we were able to control the inflammation well, but the best corrected vision was 20/40. We had lost vision in this patient. And maybe if we had started the treatment earlier in the disease, we would have avoided that. In juvenile idiopathic arthritis, we know these kids, many times they present with complications. And in the literature, we know that any inflammation with juvenile idiopathic arthritis-associated uveitis, it has a high risk of visual impairment, 2-folds, and blindness, 3-folds. And with the increasing grades of inflammation, the risk of vision loss is higher. And the literature shows that immunosuppression reduces the risk of vision impairment significantly. So this is a condition, even in the FOCUS initiative, the recommendation was to initiate immunosuppression in severe disease where the children present with poor vision, or they have posterior uveitis, or they have any complication, glaucoma, cataract, macular edema, synechiae, band keratopathy, hypotenurobiosis, iridis. Any of these complications, then you need to start immunosuppression early. With multifocal choroiditis, and this disease, also the literature shows that in order to reduce the risk of structural complications, we need high-dose steroids, more than 10 milligrams a day. And this is risky for the health of the patient. And also the literature shows that immunosuppression reduces the risk of these complications and of blindness. So it is indicated in this condition to start immunosuppression early. In serpiginous choroiditis, this is a gentleman, a 60-year-old with advanced serpiginous choroiditis, presented with the right eye lost permanently functional vision, and the left eye significant inflammation with this island of macula spared. Started the treatment with steroids and mycophenolate mofetil. So in this case, you want to start immunosuppression immediately. And when we controlled the inflammation, we had only this tiny island of the fovea preserved, vision 20/30, very narrow vision of 20/30. But again, this is in this case, if we had started earlier in the disease, immunosuppression and treatment, then we might have had a much better results. Conditions that affect the eye are not necessarily the uvea, but they pose a risk to the structural integrity of the eye, like this patient with rheumatoid arthritis, with bilateral peripheral ulcerative keratitis, with a significant loss of corneal tissue. And in these situations also, we have to recommend immediately immunosuppressive therapy because you don't want recurrences in this case, and you want to control it very fast and very early so that you keep the integrity of the eye. Other than specific entities that are either vision threatening or life threatening, from the Focus Initiative, and we know that we have to think of escalating therapy to immunosuppression when there is regional and systemic failure with steroids. Steroids definitely are used even with immunosuppression. We know that they're very effective, as Dr. Kempen mentioned, but also we know that we have to use them safely. We should try to avoid doses above 60 milligrams because of side effects, and we have to taper after 2 to 4 weeks. But also we need to always keep in mind that for the chronic use, our target is less than or equal to 7.5 milligrams. Some people even advocate less than that. Despite knowing that, a survey for general practitioners notes that the daily doses of steroids in the treatment of uveitis are just too high for too long, and not enough immunosuppression is used. And local steroids, we know that they have their uses and they're very helpful, but as Dr. Kempen just mentioned, we don't know when the effect is gonna wear off, and then we might have damage from the relapse of the uveitis between treatments. And this is something to keep in mind when we're treating patients, and think about immunosuppression if possible. So in conclusion, over the past years, treatment of non-infectious uveitis did evolve. It includes now more immunosuppression, and it includes it earlier. But also treating an individual, always we have to think about the risk-benefit and discuss it with the patient. There are certain conditions where they require no treatment, like Fuchs, and with prostenitis, there's a subset of patients who would do very well with just local treatment and no need for immunosuppression. But for potentially vision-threatening or life-threatening conditions, we have to immediately think of starting immunosuppressive therapy, but also when the local or systemic steroids fail on their own. Thank you.
Thank you very much, Rola. And with this, we move on to our next speaker, Dr. Luca Cimino, who will speak about the available immunosuppressive drugs for uveitis. Over to you, Luca. Luca, we can't hear you. You have to share your slides and unmute.
Do you see my slide?
No, you have to start sharing it. Are you sharing them with us? Yeah. No, we see your screen, but not your slide. Yeah. Now we can see.
Yes.
Yeah, perfect. Go on.
Thank you. I will speak about available immunosuppressive drugs for uveitis. As John Kempen said, we have a step-ladder algorithm therapeutic approach for uveitis, in which steroid therapy is the first step. After, we can add conventional immunosuppressive drugs, and at the end, the biologics. The steroid-sparing drugs more frequently used in clinical practice, we have antimetabolites, calcineurin inhibitors, alkylating agents, biologics. Antimetabolites, including azathioprine, mycophenolate, and methotrexate, are all used, and we use in the treatment of non-infectious uveitis, and some of them as first-line therapy, for example, azathioprine in Behçet disease or in ocular sarcoidosis, are effective also in a specific disease like VKH, like mycophenolate. Methotrexate is the most used drug and is a first-line systemic immunosuppressive therapy in juvenile idiopathic arthritis-related uveitis. If we see at all three antimetabolites, we can observe that mycophenolate has the shortest median time to treatment success. And azathioprine, as John said, has more side effects. In this case, we can see a periphlebitis in a patient with multiple sclerosis treated with azathioprine before and after with the improvement of clinical signs. In this slide, we can see the efficacy of mycophenolate in DKH, in which we see the improvement of inflammation, of choroidal inflammation, and the reabsorption of inflammatory retinal detachment. Regarding the side effects, we have to pay attention at myelosuppression to avoid infections, liver toxicity, gastrointestinal symptoms. About the malignancy, John Kamen has shown the result of SIGHT, in which the cancer mortality was not different from the general population in patients treated with conventional immunosuppressive drugs. Let's go to calcineurin inhibitors. Cyclosporin A and tacrolimus are used in uveitis in specific entity like Behçet, Beerschot, serpiginous, multifocal, ocular sarcoidosis. But we have to pay attention at the side effects, especially in cyclosporin. Renal impairment, including renal impairment, but high intraocular hypertension. And we see lower adverse event in patients treated with tacrolimus versus cyclosporin. The use of alkylating agents has decreased in the last few years because of the introduction of biologics. Biologics are therapeutic protein designed to block the activity of biomarkers that are specific target in the pathway, in the pathogenesis of a specific immunomediated disease like uveitis. And the most frequently used are anti-TNF, in which adalimumab is a fully human monoclonal antibody, is approved for the treatment of non-infective, non-anterior uveitis, and is also indicated to treat the pediatric patients with uveitis. In this case, we have a case of Beerschot retinochoroidopathy with vasculitis, retinal vasculitis, and choroidal inflammation that responds the introduction of adalimumab improve the clinical condition, reducing the vasculitis and with the improvement of the choroidal inflammation. Infliximab is a human murine chimeric monoclonal antibody, grade BC recommendation for the treatment of non-infectious uveitis. We use infliximab as first line when we have acute sight-threatening uveitis, especially in Behçet disease. We can see on the left an acute case with diffuse inflammation before and after infliximab. I show you another case of Bechet in which the patient was treated before with azatioprine. The inflammation was not well controlled, and because of neovessel on the optic nerve, we introduced the therapy with infliximab with a good response with the resolution of the neovessel. Regarding the side effect, we have to pay attention at infections, at autoantibody production, at multiple sclerosis, especially in patients predisposed. You have to pay attention at the beginning to avoid signs and to check for multiple sclerosis before to start anti-TNF. Lupus-like syndrome, there is a slightly little bit increased rate of malignancy, especially skin, non-melanotic tumors or lymphoma. Anti-interleukin-6 tocilizumab is the last step to treat juvenile idiopathic arthritis-related uveitis after that anti-TNF fails, and is also used in post-uveitis macular edema. Anti-CD20 rituximab is used in case non-responding to the conventional therapy, and there is increased body of evidence in the literature regarding the use of rituximab in juvenile idiopathic arthritis in VKH. We have two papers, one from Professor Abu El-Azhar and one from our group, to treat VKH as second line after mycophenolate, sarcoidosis. Let's go to interferons. Interferons is very useful, but the problem is the withdrawal from the market, and the action of interferon is to reduce the permeability of the endothelium in the internal barrier, blood-retinal barrier. In the literature, there are a lot of information about the efficacy of interferon in post-uveitis macular edema. And thanking to Manfred suggestions, we have been using it since 2003. And after the withdrawal of the other form of non-pegylated interferon, in the refractory case of post-uveitis macular edema, we have seen a good efficacy of pegylated interferon with the reduction of macular edema and the improvement of visual acuity. And is also used in post-infectious uveitis, and of course in sight-threatening case of Bechet disease, according to EULAR recommendation. Regarding the side effects, flu-like syndrome, especially at the beginning of the therapy, depression, leukopenia, and so on. Regarding the use of biosimilar are products that are identical copy of the original product manufactured by different company. We have no difference in efficacy, immunogenicity, purity, and safety. We use in clinical practice biosimilar of adalimumab, infliximab, and rituximab. In conclusion, the therapeutical armamentarium of non-infective uveitis is increased in last few years. Knowing the drugs potentially available in specific non-infectious uveitis is essential to improve the patient's care. The figure of ocular immunologist is very important to choose the best therapeutical option for the patients. Thank you.
Thank you very much, Luca. And with this, we move on to our next speaker, Martin Van Hagen, who will tell us what to achieve with the immunosuppressive treatment. Over to you, Martin. And as usual, Q&A is for all the questions, and we are trying to answer them in real time.
Thank you so much. You see my screen?
Yeah, absolutely.
Okay, thank you so much. So I'm Martin van Hagen. I'm not an ophthalmologist. I'm an internist immunologist working in the Erasmus MC in Rotterdam, Netherlands. And further, I'm a staff member in the Rotterdam Eye Hospital. And I'm a visiting professor in Chulalongkorn University, the Department of Immunology in Bangkok. So these are my disclosure. So I'm afraid we will have some overlap. I expected it also. So let's see. What do we want to achieve? And what we want to achieve is a treatment which is effective and results in maintenance of visual acuity without side effects. But that's hardly in very severe uveitis to realize. So I make an introduction, something about immune suppression and individualizing therapy, which the patient is, of course, also very important, and I will draw some conclusions. So my department, we are taking care with 10 internists for patients with immune dysregulation syndromes. That means a combination or a part autoimmune diseases, autoinflammatory diseases, immune deficiency diseases, and also we take care of allergies nowadays. So we are used to use a lot of biologics. It was mentioned already, many are used in ophthalmology as well. We are using them for a very long time. Actually, I started interferon alpha therapy in Behçet's disease in the early 90s, and we published that in the Lancet. And I used it quite frequently in the 90s, but after the anti-TNF drugs, I switched to them. And that once we started in 1999. So apart from that, of course, the traditional medication with the small molecular weight molecules, they were mentioned all. In the future, maybe the JAK inhibitors will be involved, and biologics biosimilars in ophthalmology, or let's say in uveitis, the plasma-derived products like IgG therapy is not very regularly used. It's quite expensive, and there are not so many studies. So what about the immune suppression? We like to decrease the activity of your immune system, and then we have to take in regard that the other speakers also mentioned, that you are vulnerable to develop infections and even malignancies. The rate is low, but we know that also from other areas like in the transplantation immunology. So what do we like to achieve in non-infectious uveitis? So reduction of inflammation, which was mentioned, and we like to avoid ocular complications. And we like to, the goal is what was mentioned by the first speaker, to have a complete suppression when this is possible. And how? Yeah, drugs using with an acceptable side effect spectrum. And it was already mentioned that prednisone or prednisolone or dexamethasone or intravenous methylprednisolone corticosteroids are still the mainstay drug in the treatment of uveitis, but not too much and not too long. And there we have the same schedule, probably as my colleagues. In the acute phase, we started steroids, but we like to taper them down to about 7.5 milligrams per day after 1 to 2 months, and then no therapy or a maintenance therapy in combination with low dose steroids. And the maintenance therapy has been discussed by the previous speakers already. So who gets what? Depends on the ocular diagnosis, of course, and also the systemic diagnosis, and also the availability of the drug, because not in every country all drugs are available. And we need also an eye to personalize the treatment in our patients from a doctor's perspective, and of course also a patient's perspective. So, as we all know, many of the patients with uveitis have a systemic or an infectious disease, and I go not into that, but we know that up to 30 to 60%, depends on where you work, probably have a systemic inflammatory disease, autoimmune, autoinflammatory, which we have to take care of, and that may differ. So methotrexate and mycophenolate was mentioned already. I included my former speakers and skipped the must trial. Alkylating drugs, I'm not using them so frequently anymore. Also in the ANCA-associated vasculitis, we use rituximab much more frequent nowadays. And when we, in our hands, when we use endoxan, cyclophosphamide, we use it only for 3 to 6 months, and then take over with another drug, particularly azathioprine. So it was mentioned also that the biosimilars are available nowadays, and let's say biologics were an extreme success in my opinion. I'm treating with the ophthalmologist uveitis now for more than 30 years, and this was really a breakthrough when we have the opportunity to have biologic like the anti-TNFs. So it's great to have biosimilars because they are cheaper, and there are only limited studies in uveitis. Not so much is known. I think when you change from the originator molecule, like Remicade, into another one, and it's the same for Humira, to another one, you have to monitor your patients. As mentioned, it can be expected that they are similar in effectivity and also in side spectrum effect, but we saw strange effects when we switch our patients from Remicade into Remsima. We published that in Frontier Medicine in 2020 because we saw in the half of our sarcoidosis patients relapse of disease and even epilepsy in neurosarcoidosis in a few patients. So be aware of that. These drugs are similar, but they are not the same, and there's a difference, especially in the glycans, in the carbohydrates, and especially I think one of the sugars, fructose, is important in that sense. So it's very good to have a registry. My experience is in daily practice, it's very difficult to get for all doctors when you see patients in the outpatient clinic to add all the information. We did it already in 2011. We never published that actually, but we had these data showing effectivity of adalimumab quite well, and activity of disease, and also macular edema. This month, there was a paper published by my group in the American Journal of Ophthalmology about 15 years of experience with adalimumab, and it's quite effective, I can say, in patients with uveitis. And the former speaker said the use of infliximab and Behçet as a first-line drug, and we are changing also more depending on the patient, depending if they can have side effects of steroids, of obesity or psychosis or whatever, to start anti-TNFs in an earlier stage. And another group published also last year a paper about the long-term safety and efficacy of adalimumab in our uveitis patients. So more biosimilars are coming up, as I've shown over here. That's why I include this this table. We have a lot of them, but still, I think we have to monitor what is happening with your patient when you change from one biosimilar of one originator to another one. The anti-IL-6, the anti-IL-6 receptor antagonists are also coming up, but they are expected to become lower. So about individualizing therapy in uveitis. So what do the doctor wants? We don't want to have comorbidities. We want to have it cheap, no allergies, and you need a vein, for example, with Remicade. The speed of action was mentioned already, side effects, but also maybe some other issues. Let's say age. We are treating more and more patients with an older age, and we have to realize that the pharmacology is changing in time. The immune system is changing in time, and we have to take in regard that people above the age of 60 have many other disorders, and that is really something of importance. And it is assumed that nowadays 30% of the indications for a biological in elderly is not given, and that's something to take, to keep it in mind. But also that other drugs have a more severe side effect spectrum when you get older, when you have hypertension and also diabetes. And do not forget, and that's a clinical experience, and we didn't publish that yet as a one publication in literature, the combination of certain diseases like diabetes and sarcoidosis. That is really exaggerating the organ damage in patients with sarcoidosis. And we try to treat these patients, because you do not like to give steroids in diabetes, to treat them with anti-TNFs. Macular edema has been mentioned already. There are a number of drugs that can be used, and the ophthalmologists give it locally. Sometimes systemic disease. We still use the somatostatin analogs, which were not popular. We published that 25 years ago in the New England, but it was very expensive. But in quite some patients also effective. In our hands, there are no regular studies, and tocilizumab is also of interest in my opinion. We are using that also in macular edema in patients with uveitis, and we have even a research program going on that. So genetics, yes, probably too early, but I think we are going that direction. We can read the DNA of our patients, and we can, for example, see if there are mutations in the TPMT gene that mutation in there are causing myelosuppression in patients in who you start azathioprine. That can be important. And also yeah, we expect also to detect or discover more and more genes that are involved with retinal diseases. For example, a patient of mine, we published in 2019 with Rosa syndrome. It's a retinal disorder, but also anhidrosis migraine. It's an auto-inflammatory disease. And we know when you have this disease, drugs do not much in the early patients that have been described. They didn't have much effect on the course of disease in my patients, but more studies are needed. And the mutation is in the alpha protein kinase 1 gene. So what about the patient? Yeah, the patient want to study, the patient want to work, reduce the days off, want to have leisure, want to travel, want to get pregnant, that was mentioned also already, which is extremely important, that the treatment will be part, the burden of treatment will be part of their life. So what do we need to improve that? Yeah, I don't know if we are doing it well, but we have a multidisciplinary team. The ophthalmologist is central, and the nurse practitioner, and we take care of the systemic treatment, but also other specialists like medical immunologists, psychologists are of importance, and I think in the future also the geneticist. So I end up that there's a challenge for non-infectious uveitis. It's heterogeneous, variable clinical course and outcome. There are not so many evidence-based studies, because of the heterogeneous character of this disorder. And I think we have to look to the future because the therapy has to be more personalized in the future. And that may be by improving imaging and molecular and cellular diagnostics, genetic approaches, use of omics is important in these rare diseases, and increase the evidence by clinical trials and combined registries. So this is a group who works in Rotterdam on uveitis, scleritis, and the orbita. I thank you for your attention.
Thank you very much, Martin. And with this, we move on to Christopher R., who will talk about what determines your choice of treatment, and then we will take up the discussion.
Thank you kindly for the introduction. And on behalf of the Women I'd like to thank you for the organizing committee to allow us to speak. Today, we'll be talking about a topic called What Determines Your Choice of Therapy?
Christopher,
And we will...
could you please
Yes.
go to the slideshow? Yeah.
Oh, is it not showing?
Yeah.
Yeah.
It's just
Give me 1 second.
now.
Perfect. How is that?
Yeah, perfect. Thank you.
Excellent. Thank you so much. Let me just quickly here. Perfect. I have no financial disclosures of notes. And so as background, as many of us know, and a lot of the information will be reiterated, but I think that will be helpful here. Chronic low-grade inflammation often results in poor visual prognosis and can result in permanent damage to different ocular structures. And so the goal, therefore, should be clear that we should tolerate no chronic inflammation. But as aforementioned with my colleagues, that no chronic steroid use, especially high dose, and no serious drug-induced problems should be tolerated either. And so our preferred practice pattern is remission, and that really should be the mission when we treat patients with uveitis. But the prevalence of visual disability and blindness, despite having steroid therapy, has been a little bit dismal. Steroids, a little bit, as mentioned by from some of my colleagues, is a major advance that began in the 1950s, remains a cornerstone in the treatment of uveitis, but it may always produce trouble if it's used chronically, especially at high doses. And patients such as this, it's fortunate that we don't see that very commonly, but it could result secondary to chronic steroid use. And so evidence-based analysis of peer-reviewed literature indicates that the prevalence of visual disability and blindness secondary to uveitis has not measurably changed in the last 30 years. But why is that? How can that possibly be? And so it really depends on training. There are a lot of ophthalmologists out there to complete their residency training may have not been exposed to different types of uveitis treatments other than with steroids. And in a study that was done about 10 years ago here in the United States, that polled practitioners on their use of steroids in treatment of uveitis, we see that actually a large percentage of them use steroids to induce remission, and a lot of them use it high doses for maintenance as well. And up to 75% of physicians were not aware of the treatment guidelines for uveitis. But those of them who were aware had really good adherence to the guidelines. And so it really is what we call a legacy of ignorance, in that there's a failure to lead, to educate the resident fellows, the patients and colleagues as well about the safety and use of IMTs in the treatment of ocular inflammatory disease. And we're trying our best to use these medications to hopefully introduce them to the crowd and to the ophthalmologists. Hopefully that'll be helpful in the treatment of our patients. And so, as mentioned previously, what determines how we treat these patients, or the therapeutic principles that we have. Ultimately, the goal is to preserve the function, to preserve the vision of these patients. But the first most important part is understand the diagnosis. And within that, understanding the diagnosis, understand the activity of what we are treating is of utmost importance in how we determine how we treat these patients. The risk-benefit ratio of a lot of the therapies that we use are also important to consider, and becomes a little bit of a consensual or consent process with the patients or the patient's parents in some cases as to what is the best option going forward. And as mentioned multiple times in the past, but it's incredibly important in determining the treatments, it's a step-ladder approach that we use in selecting therapies that may have less side effects to start first to see if that will be helpful for some of our patients. And so the recommended model of the care of the patients with uveitis really starts with the accurate diagnosis. And so the major crossroads that we initially cross with some of our patients determining whether or not they have infectious as opposed to non-infectious uveitis, because that really dictates how we treat these patients at the onsets. If practitioners are unsure of the disease is chronic, oftentimes referring to someone with more experience dealing with uveitis entities would be helpful. And if they're appropriate for immunomodulatory therapy, then referring to someone or managing yourself could be an option going forward. General principles, of course, if it's infectious, you should treat with antimicrobial therapy with or without some steroids. And there are multiple cases as listed by my esteemed colleagues. General principle in that steroids is used often actually for idiopathic and autoimmune cases. And steroids remains one of the best options that we have to induce remission in some of these patients, whether it would be topical, regional, intravenous, or intraocular. Non-steroidal medications could also be employed, whether topical or systemic. And systemic NSAIDs could be used, and sometimes it's an underappreciated strategy, underappreciated rung and the ladder that we use to prevent recurrences of inflammation in certain cases. But of course, the side effects profiles could also be there as well for systemic NSAID therapies. But what about cases such as this? And patients such as having diagnosis of relapsing polychondritis, for example, which could present with ocular manifestations commonly. How do we usually treat with some of these patients? And so a lot of the cases, as again mentioned by my colleagues, a lot of these cases required immunomodulatory therapies because they are potentially life-threatening. Those conditions with more systemic symptoms, we really consider these IMTs at a more early stage. Diagnoses such as GPA or relapsing polychondritis, as mentioned before, or Behçet's, and the list can continue with PAN, RA with necrotizing scleritis, or SLE with a lot of systemic effects as well. These conditions really should be considered to start these immunotherapies, immunomodulatory therapies earlier. What about cases such as this? A 70-year-old Caucasian female with blurred vision in both eyes, with some vitreous cell in haze and mild CME. And here we see some deep yellow choroidal lesions here. With the thought that it could possibly be birdshot, different laboratory investigations can confirm that. So how do we treat conditions such as this? And so as presented by some of my colleagues already, treatment is often necessary in these conditions. And there are no really defined treatment regimen. There are a lot of different medications that could be used, including cyclosporin, methotrexate, or even biologics for these cases. But this bird chart falls within the category of conditions that can be blinding. They're severe inflammatory ocular diseases, and literature has shown that they require immunomodulatory therapy. And long-term outcomes with corticosteroid monotherapy tends to be poor. And there are the list of these conditions that we really should consider treatments with immunomodulatory therapy earlier, such as SO, VKH, MFC, and Bird-Shot falls within this category as well as serpiginous, as mentioned before as well. So not only do we start these medications on patients with conditions that can have systemic effects, we also should consider them in inflammatory ocular conditions that could be difficult to control otherwise. But what about cases such as this? This is a case of a 10-year-old boy from Mexico City presented to a clinic with bilateral postmenitis for the ear. And so the diagnosis here isn't the issue, but the management of it. So there's been treated with topical, regional, or systemic steroids, which are steps that you take in the step ladder that we use to manage some of these conditions. This boy has a negative investigations, visual acuity is trying 50 and 30, and we see here some signs of activity, that there's some snowballs inferiorly and some snow banking as well. And so in a case such as this, which is trialed multiple different therapies, what are some of the more reasonable things to try next? Should we continue some more local therapy, give it some more time, or do we consider some surgical approaches, or do we consider using some systemic IMTs? And so it really comes down to a discussion, in this case, with the parents, to weigh the risk and benefits of these different therapies and how we use it to treat patients like this. And so regional therapy was thought to continue at this time point, and risk and benefits of the other therapies were given, but the patient did not seem to be improving much. And so the patient was actually taken to the OR, and vitrectomy with corpexy was done. This is a few years ago now. And visual acuity actually improved. The patient presented with improvement in his symptoms and signs, and there's some cool sequelae from the surgeries there. And so in cases such as this, in which we really don't have the dictates to using systemic immunomodulatory therapy initially, we can consider different steps in the step ladder that we have, whether or not it'll be regional steroids or oral NSAIDs or oral steroids, to some of the surgical approaches that we may have to using IMTs. And certainly there are lists of IMTs that could be used in cases such as this, with the goal of being in remission for upwards of 2 years with no inflammation should be our goal. And there are lots of different medications, as with other different uveitis entities. A lot of different medications have been trialed and used and listed in the literature. But there are also a list of conditions that we should consider therapy for. These conditions tend to be more chronic and more recurrent. Things such as JIA or TINU or HRB27 that could be more severe. And so it really kind of emphasizes the importance of early referral, because some of these managements are really can be tricky for ophthalmologists. And the importance of partnering with someone and having some collegial collaboration with someone with more experience in dealing with these uveitis entities could be helpful. And so the preferred practice pattern, of course, the model of care that strives for steroid-free, durable remission and doing whatever it takes to really achieve that goal. And this list of medications here has already been reviewed by some of my colleagues here. And this list of medications continues to grow on almost a monthly or annually basis. And there are a lot of different infusions that are coming out, including the IL-6 inhibitors from the Stop Uveitis trials, to IL-17 inhibitors. We're currently it has been presented before with secukinumab, but it's been looked at again with some of the clinical trials that we are running here. And so the step ladder approach, again, should be the philosophy of trial, doing whatever it takes, taking different step ladders, different steps on the same ladder to make sure that we attain that remission, whether or not it will be from specific therapies, to steroids, to immunomodulation. And again, just as a review, the IUSG and the AUS has listed different conditions that are indications for using immunomodulatory earlier. And so cases such as SO or VKH and Behçet's with relative indications such as intermediate uveitis or retinal vasculitis, and GIA-associated ones as well. And the AUS with a consensus-based recommendation also has similar evidence as well, and that there's good evidence for the effectiveness and the need for immunosuppression in a variety of conditions, including serpiginous and Burchard and others. So in summary, of course, we're eager for new and better and safer drugs in the treatment of some of our uveitis patients. And we wait with great hope to attain that while avoiding some of the side effects and really monitoring some of the side effects that we have for some of these therapies. And so in summary, in how we choose and what determines our therapy, there are lots of different factors that really go into that equation. Accurate diagnosis, of course, is key. And in that, understanding the disease course also plays a big role. If the disease course is known to be more benign, then we may select more monitoring, observatory, or more benign therapy options. But should the disease course and disease diagnosis really require the early use of immunomodulatory therapy, and that really should be employed at the onset to prevent some of the complications that we may see in these patients. And risk and benefit ratio, as we discussed before, is especially important. And like oftentimes we like to include some of our patients in that as well, so that we come to a consensual decision. And a step-by-step approach, again, just to reiterate, is very important in selecting what we use and how we treat our patients. And with that, I thank you for your attention. I look forward to the questions.
Thank you very much, Christopher. And now is the time for controversies in uveitis and the discussion. You know, this used to be the favorite section with Manfred. So before we take up this section, let's collectively take a brief moment to send our love and prayer to Manfred. I think he's somewhere around and watching us, so we better do a good job at this webinar. Well, all of you, those who have been sending prayers, thank you very much, and I would pass it on to his family. Thank you very much, and now we go to what Manfred would cause as controversies. I think one of the important questions for all of you, and all of you stated very clearly that corticosteroids are still the first line of therapy to be used to take care of inflammation. Now, for whatever reasons, if we cannot give corticosteroids, what would be your choice of treatment to reduce the inflammation instead of corticosteroids? So can we begin with John?
So, you know, I'm mostly practicing in Ethiopia now, and we really just have methotrexate and azathioprine. I would, you know, pick one of those. I think if it's not likely that that would work, and you have a broader range of options, you know, and your insurers are not squeezing you, you know, biologics like TNF inhibitors might be more likely to work. So that might be what I would like to use.
Because TNF inhibitors are faster acting compared to others.
I think so,
Okay.
yeah.
Would you agree with that, that if for some reason we are not able to use steroids and there is active inflammation, TNF inhibitors?
Yes, we are doing that more and more, actually. Let's say we have a lot of patients referred. So they tried already steroids, for example, in sarcoidosis. And then we see the many with diabetes, in which I like to stress that because that's a terrible combination. And nowadays we start infliximab directly in these patients, and also patients who had a history of psychosis or whatever. When there's something wrong, we give that a try. And what also was mentioned in Behçet's disease, it's working very well in neurosarcoidosis as well. So we are going into that direction, or even when it's very severe, we combine. But
So we understand that if there is a diabetes or comorbidities, TNF, anti-TNF would be the first choice for you. And John.
In some indications, it is. Because we are, otherwise you get the complications of other diseases like the diabetes that's going completely wrong. And there's something, maybe it's not the discussion point at the moment. We look at all genes of sarcoidosis and also all expression profiles. And then you see continuously STAT1 interferon gamma coming up, but also insulin, part of the pathway of the management of diabetes. So in these diseases we are doing that, but there's still always a discussion: do we or do we not?
So Luca, do you have any experience of using interferons as a first-line therapy if you cannot give steroids?
We have used in case of Behçet, in which the phenotype is characterized by vasculitis and macular edema. And if we have a contraindication to the therapy with steroid, for example, in diabetes, or because also the use of steroids inhibit a little bit the action of interferon, we prefer to use interferon alone. The phenotype vasculitis and macular edema.
To be very honest with you, we don't use interferon much in India, but it's a good option. Christopher, you were about to say something, I think.
Yeah, I think an option that I like to use in clinic, if induction of remission for inflammation is something that we're thinking about, since we can always employ some of the more local options. Of course, you gotta think about the complications of such to induce the remission of the inflammation while we wait for some of these agents to sometimes work. And methotrexate, salmeterol can take months. But if you have a depot of Ozurdex or something along those lines, that could be used in these cases to kind of bring down the inflammation more locally. I think that could be an option that could be considered as well. Of course, it's patient dependent.
Rola, there was a question that you answered, that if you are starting the patient on anti-TNF, would you look for optic nerve imaging? Because there are some reports of toxicity and AIV. And you answered that you do get MRI done for your patients. Can you elaborate on it further?
The MRI brain,
Yeah.
MRI brain prior to anti-TNF, just a baseline for the risk of demyelination mostly, not only in Behçet disease. So in general, if it is possible, if we can do it, I try to do it before I initiate anti-TNF, especially in intermediate uveitis. But in general, if it is possible and it's easy, covered, I would do it for that, not looking specifically at the nerve for optic neuropathy. No.
So there is a question from Ashraf, and probably Martin, it's for you, that what about the effect of IV immunoglobulin or plasma electrophoresis? Like, I would add that, is there any situation you will consider that as first-line therapy without trying anything? Or is it always a last resort when nothing works?
Vishana, it's a good question. It's absolutely the last resort. You can think about this therapy in autoantibody mediated therapies, diseases, in which it has an effect. High dose immunoglobulins induce more regulatory T cells. So in that way, it may help, but we use it in certain entities like dermatomyositis and Guillain-Barré and these kinds of diseases, which is quite successful, but hardly in ocular diseases, actually.
Well, the second issue, which is very common, especially in the countries like ours, that many a times
We lost her for a moment.
Yeah, I guess we'll have to wait for her to get back on.
Yeah. Maybe I try to answer somebody who asked about increasing dosage of methotrexate and folic acid. Our schedule is until methotrexate, I was lost with typing of, it disappeared. When you give methotrexate until the dosage of 15 milligrams per week, we give only 5 milligrams of folic acid more than 24 hours after the methotrexate dosage. And when we go above, then we give it 10 milligrams and then 2 times per week. And also, of course, more than 24 hours after the dosage of methotrexate. For these disorders, autoimmune disorders or immune disorders, we never go above 25 milligrams methotrexate per week. I was typing it, but something happened.
Okay, yeah, something happened in between. So I will repeat my question, that how would you taper the biologics?
To me?
Yeah, you can start.
Luca?
Luca?
Yes. Regarding the anti-TNF in infliximab, we prolong the weeks of administration. After that, we have a stable situation. Regarding the adalimumab, we treat not every 2 weeks, but we stop at 3 weeks, but for few months, 1 or 2 months, and after we stop.
Okay. So, Rola, is the protocol same for you?
No, I usually take longer because I space it at longer intervals. But for example, with I'm always concerned, especially if their presentation with aggressive, vasculitis or posterior uveitis. I'm always concerned to stop. So I space really slowly, and I usually take my time spacing. At 3 weeks, I usually give it 3 months before I consider tapering more or spacing it more, just to make sure that there is no recurrence. I always think of the 8 weeks on average where we would see a recurrence when you stop the treatment. So I want to pass that point and then space it more. So I'm a bit more cautious.
So Christopher, in your experience, like we all say that when you are using immunosuppression, the endpoint by and large is 2 years. Now, how about biologics? Do we have a figure for that? Is it 2 years longer?
Yeah, that's a great question. And so the extended use of these medications always brings a little bit of a worry, especially in some patients and depending on what they read in the black box warnings and so on. But in our clinical experience, we try to use it, or if it's inducing remission, we try to continue it for at least a year. And we want to really watch that the disease is actually stable and being managed on these medications. And then we, as Hammam said, we usually taper really slowly thereafter. And I mean, it's not uncommon for some patients are clinic that are on Humira like every 4 or 5 or even 6 weeks. Because I mean, we just want to make sure that the patients are nice and stable prior to discontinuing it, and we just don't want to risk that flare.
Dr. Martin, there is probably a question that you can answer best, and that is from Dr. Bestway, who's asking, is there a preference or difference between folic acid or folinic acid added to methotrexate?
Yeah, I'm afraid I make there's a difference in from Dutch to English in that sense, because we are only. I think the translation of what we are using from foliumzure is folic acid, and there's also folin acid, but I'm not have experience with that. So that's a small change in that.
Yeah, you meant the folic acid. Now I have a question to all of you. In your talks at different stages, you mentioned that if it is refractory, you could use tocilizumab, you could use rituximab, and then somewhere along the line comes JAK inhibitors, checkpoint inhibitors. Now, how do you use which one to use when?
Shall I start?
Yeah, you, John, Rola, everybody.
Absolutely not. I talk too much. You know, there's not much experience with JAK inhibitors in uveitis. There was at the uveitis meeting one example that looks promising, and there was a review in Nature Reviews Rheumatology last March about what trials are going on with JAK inhibitors, and there are not many trials going on as usual in our uveitis profession. And I think it may have, yeah, it probably can be used. I did it in very refractory sarcoidosis, and there was no activity of uveitis anymore in that patient. We are using the JAK inhibitors in patients with genetic defects, in which there are gain of function defects in the STAT3 IL-6 pathway. That's interfere there. But we have to imagine, I think, they are stronger than mono-directed biologics, because they are acting on the cell membrane receptors. They all act through 3 JAK molecules and 1 tier 2, and then go into the cell, giving a broad spectrum of possibilities. And probably we have to take in regard side effects, such as herpes infections, which JAK inhibitors, what I saw already. So I think that probably there will be a place, maybe after a mono-directed biological.
Sure.
Because you cover more growth factors with JAK inhibitors. But yeah, we need trials.
Agree. John, in your experience, when you start biologics and patient goes into remission, but the patient is also receiving corticosteroids or immunosuppression, and during remission now you want to start reducing, what would be the first to go, cyclosporin or methotrexate or steroids?
You mean adding it to TNF inhibitor?
I mean, no, the patient was on this treatment and then you added biologic, and then the patient continues on all these treatment and biologics. So how would you go on reducing or stopping them?
Yeah, I think corticosteroids would be the first priority, and the others would probably depend on other considerations like the cost. You know, if cost wasn't a consideration, I might prefer to, there's an impression that the TNF inhibitors might be more potent. You know, that's being assessed in a trial now, but we don't have the results. You know, so I might prefer to leave those on if cost wasn't a consideration, but it always is. So yeah, so one might, you know, reduce that first for economic reasons.
In your experience, have you ever reduced the dose of immunosuppression when you are tapering them off? Say azathioprine, for example. would you just stop it one fine day, or would you reduce the dose, watch out for the recurrence, and then stop?
So I used to think that there was no evidence that just stopping it was any different than tapering it, since it's such a long time to have the effect. But I had one or two instances where I didn't like how that turned out. And I think most people do taper it. So I don't think there's a strong evidence to decide between those, but I've been tapering it.
Yuka,
I-
what do you do?
It depends of the clinical behavior, but if there is quite after 1 year and that I have to stop the therapy, I stop in 2 months. We give the therapy, the full therapy, 2.5 milligram per kilo, and after we continue in half regimen, and after 1 month we stop.
I would like to just comment on one thing that's been alluded to that's related to this. So it was mentioned that the target of therapy could be to get off of everything in 2 years, but I think this depends a lot on the consequences of a relapse. So Rola alluded to, there may be cases of Behçet's disease with retinal vasculitis, and a relapse might permanently extinguish vision. So that's a different situation than if it's sort of a JIA case that sees well, and they might get a few cells, and they're cooperative and come back to be checked. That I might feel more free to try to stop things if they're controlled for a long time. Although I have the impression that JIA usually lasts for a very long time, so maybe that's not a good example. But say it was like intermediate uveitis or something, and like the bad consequence will be that they get reversible macular edema or something. I feel more free to try tapering off. We've been working on a series of remission tapers, and remission really isn't very frequent. so often they're going to relapse. And I've had the impression that when people say how long they treat before they try tapering off, that number keeps getting longer. So I suspect that's because often they do relapse. But on the other hand, if a relapse is not likely to cause a permanent problem, it's reasonable to try tapering off from time to time.
In my experience, I generally get a fluorescein and ICG done before stopping them to see that there is no subclinical disease lurking somewhere which I might have missed clinically. So, So Rola, you belong to a country which I guess has TB and other infections. So there is a question from Dr. Mamuri, who is asking that could we use immunosuppressive therapy in TB infections, because not many times, but sometimes the TB is controlled, but you still have vitritis or inflammation that responds to immunosuppressive therapy. So would you be comfortable, and which drug?
Usually when they're on anti-TB treatment during those 9 months when they're taking the anti-TB, I could be giving steroids, to control the inflammation. But after that course, after they've finished their course with anti-TB, you want to get rid of the steroids now. You can't keep them on a higher than acceptable dose. Then yes, in that case, I do give them immunosuppressive therapy. We've used mycophenolate, mofetil for that, methotrexate. I haven't used biologics for that in that particular situation, usually an anti-metabolite. But it's usually after the course of anti-TB is completely done, and I try to get rid of the steroids, and then I need a higher dose than acceptable, and I need to give them steroid-sparing.
Now, Christopher, another question was that your uveitis seems quiet. There are few cysts seen on OCT, but the macula is not really thick. Would you keep on chasing those cysts with giving more injections, or would you just call it a day?
Yeah, that's a good question. And so a lot of times we try our best to get rid of any inflammatory signs and symptoms, but like why I see a lot of different like edema cases out there. I mean, sometimes you just can't get rid of everything. And so, as opposed to chasing things, usually if I see that it's stable and it's not causing a lot of structural sequelae or visual symptoms, then sometimes I like to take a more of a watch and wait approach to see whether or not that's actually going to manifest into something more prior to treating it a little bit more. That's a good question.
Yeah, thank you. And coming to tocilizumab for intravitreal, tocilizumab for macular edema. Martin, you did speak about it. Can you share your experience about it?
Yeah, we are, when we are treating patients with a major CMA component in the uveitis, not reacting enough to anti-TNF drugs, we have some success with tocilizumab, and that's why we are in that stage of after anti-TNF, and I'm waiting all the time for studies, and there are studies who do not show much effect, but our studies are small studies that show some effect. We have I have also immune deficiency patients who have a defect in STAT3, and we make a mouse in Bangkok with a STAT3 gain of function problem, and these patients have vasculitis, looks like vasculitis, and a lot of macular edema. So we now make cell lines and to study that effect, because STAT3 is highly expressed in retinal pigment epithelium as well for that function. So I can imagine that there is, and also express the IL-6 receptor. So basically, I have a good feeling with it, and we have some clinical experiments, but I think at the moment we know that already for 8 years or something, not many people are working on tocilizumab. Maybe John has also an idea about that, or Christopher, but what their opinion is about it.
So there is, yeah, John, please go ahead, sorry.
So ARVO 2019, I saw Glenn Jaffe presenting a drug company's large trial about this, and it seemed to be pretty persuasive that a number of cases have macular edema get better. And so I don't think that these things always work. The studies that I've been involved in, we don't see 100% of macular edema get better. So a lot of cases will get better, but not all of them.
Maybe we have to, and that's for the future, the genetics, identify the patients. Are these patients with higher active IL-6 receptor, STAT3 pathway, which also influence your mitochondria? So that's something for the future.
And talking about future, there is an interesting question by Dr. Ashraf, who says, are there any immunosuppression local implants that we can use in future? So Christopher, do you have something coming up in the pipeline?
And so, I mean, there are a few trials that we are running here that take a more of a gene therapy approach into producing some of these immunomodulatory agents kind of in vitro or in vivo, in this case, via injections or subretinal injections. But certainly they are more kind of investigatory in nature, and probably going to be a while before anything like that happens.
So nothing is yet. So Rola, you have been talking about multiple sclerosis. Now there is a question that the patient had intermediate uveitis, many years of steroid, unsuccessful trial of azathioprine, and then developed multiple sclerosis and now getting worse. Is there any safe option to immunosuppress her? What would be your drug of choice here?
Mycophenolate mofetil would be a good option because it also has some response with multiple sclerosis. So sometimes when I'm treating such patients with a neurologist, this is an option to try in the situation because it might be also helpful for the multiple sclerosis.
And Luca, what about interferons for multiple sclerosis patients?
works very, very well. And we also, in some difficult case at the border because of multiple sclerosis or Behçet, we use azathioprine.
Okay. Any particular drug you will use categorically for sympathetic ophthalmia? That's the question from Dr. Chelarani. Any particular thing you will use, or it's the routine, whatever goes on? John?
It's such a rare thing. I don't think many of us have a huge amount of experience with it, you know, so the 1 or 2 cases that I've seen, I have treated similar to panuveitis, where I might start with conventional immunosuppression, and if that seems to work, then that would be fine. I don't think we had biologics back then, but you know, I might progress to TNF inhibitor if it didn't work, speculating that it might be more effective, maybe.
Sympathetic ophthalmia patients really do very well with the initial high-dose corticosteroid followed by immunosuppression. That should be started at the earliest, like depending on your country and your experience. And
one thing that we saw, like with the MUST and my clinical experience with the long-term registered implant, was there were some cases that I just couldn't get under control. And, you know, I think there's less of those with TNF inhibitors maybe, but the registered can be an option, you know, if you just can't control it or if there's strong contraindications to the systemic therapy. So I think it's a reasonable second line treatment.
We will take up one last question, and after that there are still 4 questions which all of you need to answer in the Q&A box. And the last question, Martin, is it for you? Hearing about STAT mutation role in autoinflammation, should we do genetic testing in uveitis patients? I think you already told us, but just once again.
Yeah, I love it to do, but you know, we do not have many defined genetic uveitis syndromes yet, but I'm sure more will come up. And like in the one I showed you with the alpha protein kinase 1, it's a very destructive disorder. It's nice to know that there is a defect, and we have not a real therapy yet, but then you can know what you can expect. But there's also in the autoinflammatory diseases, indeed, Merkel-Wells, hyper-IgG. Hyper-IgG gives also a kind of retinitis pigmentosa like disease. And I hear also always, because I'm not treating retinitis pigmentosa only with when there's macular edema, we give somatostatin analogs or other things. It's nice to know, because I hear from the ophthalmologist that is sometimes difficulties to make the diagnosis between inflammatory kind of retinitis pigmentosa and uveitis. So sometimes it's behind. So I think we are climbing up the mountain to do more genetic investigation. And I think also in the more polygenetic disorders in which certain pathways are involved, like the STAT pathway, then we know, like STAT3, we have to inhibit IL-6, or, you know, in these IL-1 driven pathways, you can more give a more secure or personalized therapy. We are not there yet, but I expect that it will come.
I wonder if there will be some pharmacogenetic studies too that might prove in the future to be useful for predicting which immunosuppressant might work.
Yeah.
Yeah, that should be great.
Yeah.
Mm-hmm.
I have one remark from, oh sorry, Christoph. I have one remark about the folinic acid. When I do not know if there's a translation trap in it, because I'm looking at the internet. I know there are folic acid compounds, and folinic acid is an active folic acid compound, as I understand well, which is active and used many times in oncology, and it's also given in when there's an overdosage of methotrexate. So it has to do with that, and many times it's given intravenously. So I look at the internet. What is the difference actually? Sorry for that.
Well, with this, we come to the end of the webinar. As usual, please fill up your CME credit forms, which you will receive by email, and you will get your certificate. And the next in the series is on 1st of October, where we will kind of continue and talk about the rheumatologist and the role of rheumatologist and uveitis and arthritis. Well, we will try to keep the legacy that Manfred has created live, and we'll try to carry out whatever webinars he's planned and continue to educate our colleagues in the areas where we cannot be there in person. Thank you very much, all the speakers. Truly, truly appreciate you spending time with us on the weekend, especially with all the traveling and everything going on. This will be a resource that will be available all the time on our IUSG website. And thank you very much for your contribution towards the education. Thank you.
Thanks.
Bye.
Thank you.
Thank you.
Bye-bye. Thank you so much.
Bye-bye. Thank you.
Thank you for stepping in the gap,